COVID vaccines. And we are joined by staff and our manager. We're going to be looking forward to a presentation and then asking some questions. And as I was saying earlier to a few folks, this feels like a huge step forward that we're gathering together for a work session, not on trying to figure out the disease, not on, I mean, we're going to continue to work on that and can be concerned about it, but we're on for the first time a work session on vaccines, which to me means we've come a long way into this dark forest of the pandemic, if you will, and we are now coming out the other side. There's a lot of dark forest to go, but we can sort of see the end of this difficult journey. So, Mr. Manager, with that, I will turn it over to you.
Thank you, Madam Chair and members of the board. I'm going to turn it over to Dr. Varghese in a minute, and Aaron Miller is here, our Director of Emergency Management, along with Jim Schwartz. One of the things that I think people will gather as we work through all the information, and there's a lot of information to share, is that the information is changing and is going to change a lot. And one of the things that I hope people take from this is that we do not have all the answers. And as a matter of fact, each answer seems to spawn a whole series of questions. And so I'll leave it at that. I want to make sure that we leave plenty of time for conversation, because I know in speaking with each of you and also speaking with Dr. Varghese and Dr. Miller that there are just a multiplicity of questions out there. So I'm going to turn it over to Dr. Varghese. Ruben?
And Mr. Schwartz, and Dr. Varghese, if I could interrupt real quickly, could we, if you guys find a good point to maybe take a break and take questions so we don't save it all to the end, maybe that would be better. So just let me know, okay?
Absolutely.
Okay. Hoping I'm not on mute.
You're good.
Okay. Good afternoon, everyone, and thank you, Kendra, for putting those slides up. Obviously, it is good news to be able to talk about vaccine, and I think it's also appropriate to do some updates. And so, as the manager has told us and put out, there is stuff that we know, and obviously it can change, and we won't always have the answers. And we'd rather be honest about that and build the trust in what we know. And so I wanted to show you kind of the agenda for this presentation, which would be on the next slide. So we're going to review the numbers, some information on case and contact investigation, quarantine timeframe, testing, a long section on vaccines, and what folks can do now. And so I was going to propose, Madam Chair, that at the end of each of those areas, we leave room for all of you to ask questions, if that sounds reasonable.
Sounds excellent. Thank you.
Okay, so moving on to the COVID numbers on this slide. Thank you, Kendra. This is the pandemic curve for Arlington since our first case in March 2020. And I hope that people can see that we have hit our highest number of cases for the entire pandemic in week 49 of the year, okay? We hit 501 reported laboratory cases of COVID. I'm going to let people sit with that for a few seconds. That's a very sobering number. And so there could be numerous reasons for it, including more testing available and more demand for testing. And Dr. Miller will get to that in the section on testing. But I need to remind people, whatever the reason, it illustrates that we have a lot of cases in Arlington, and this is what's happening in the region and the nation. And in Arlington, as you can see, it has been essentially on a steady rise since the first week of October. And it really does frame some of what I'll present and Dr. Miller will present in the upcoming slides. But I wanted to give you, Madam Chair, and the board a chance to respond to this or ask questions at this time about this graph.
Thank you. Colleagues, anybody have a question? Because I'll come up with one. I do see a hand up, but I can't tell who it is.
That's me, Madam Chair.
Go ahead, Mr. Karantonis.
The obvious question, truly very, very sobering number, the 501 cases. And this is in the gray zone of week 49. So we expect it reasonably to be even higher in reality, right?
Correct. And let me use this opportunity, thank you, Mr. Karantonis, to let me explain that. The areas that are in shade and grade is a way for us to remind everyone and ourselves that there is a lag sometimes in disease reporting and laboratory test reporting. So these are the materials we currently have. And so if more people got tested and there's been some delay in that reporting, those numbers would be higher.
So Dr. Varghese, do we have any from previous weeks, since we have been in that for quite some while, do we have an idea, a mathematical estimation of how many more this may be?
No, there's no way for us to be able to predict that because we don't know the behaviors of who's seeking testing and when and so on. But obviously, the concern at this point is how many people may have traveled and gotten tested for their travel during the Thanksgiving holiday or in preparation for that or post those things. So that's something that we don't have ready access to, like in real time, to know what could be coming. And so it's just one of those things that we don't know the denominator of the number of people getting tested. We only learn that after the fact. And unfortunately, with some of the new technologies, like the rapid tests, we may get the positives, but we may not get the negatives for a while. Not that this would show us the negatives, but we don't necessarily know how many people had gone for testing. There will be delays in that reporting as well, and Dr. Miller will get to that in his section.
Okay, thank you. I guess about the load that this implies to our health care system, et cetera, we'll talk a bit later.
Yeah, I think that will come. A good question, good point.
Thank you.
I'll go to Ms. Crystal.
Thank you. Dr. Varghese, when you last presented to us, you shared some really insightful data about based on contact tracing, where the majority of people seem to be, if not contracting COVID, then at least reported being. I think number one, for example, was working outside the home. Do you have any reason to believe that those behaviors leading to this drastic peak have changed? Are they roughly the same ones, do you think, that are still driving the increase? Or are we getting some information that might indicate there are other behaviors or changes in behaviors or things people are doing because they are fatigued of quarantine that is driving this new peak?
Very good question, Ms. Crystal. So we don't have any evidence to suggest that the behaviors are, like the categories of behaviors, have necessarily changed. Obviously, what has happened since we last presented, the governor has had new executive orders limiting certain behaviors and so on, or at least rather than limiting behaviors, how many people can congregate with each other is probably the better way of putting that, although there have been some specific things in the executive order. So obviously, we'd love to be able to see some improvement in the numbers with time, but that is often a lag indicator. We won't know what people are or are not doing until after the fact. And one of the things that I'll get to in the contact tracing and case investigation, but it's an opportunity to talk about it a little bit now, is we are going to have to prioritize case investigation because we did the same when we got to 306 back in April, May. Even though we're hiring more people, we can't get to all of this in a timely fashion, and or if the results come in well after the fact, if it comes 10 days later, there's pretty much, no ability to stop that case from having had impact because of the impact on the whole system. But I'll get into that. But it's a very good question. We have no reason to believe that the behaviors have necessarily changed. We'll collect that as we go on. And then as we have time, we will look at that data. And also to Mr. Karantonis's point, this is what I'll get to in the next section. But we are part of the healthcare system. And so this is one of the reasons why we ask people or talk about in pandemic planning, we're trying to flatten the curve so the impact on the healthcare system is able to respond to these things. Fortunately, my staff doesn't get exposed in the same way as the other healthcare workers, but as this happens, the load and the ability to respond to it is much more difficult. And this is something that's happening across the nation. I'll get to what CDC has allowed and VDH has allowed us to do.
All right, thank you. I will go to Mr. DeFranti, I think was up next, but I'll just insert a quick request. Dr. Verghese, in the future on this chart, could we also add the governor's most recent order on bars and restaurants just to see if there's any connection?
Sure, will do. We just didn't have time today.
Oh, so. Yeah. No. I totally understand. Thank you. Mr. DeFranti.
Thank you, Madam Chair. Dr. Verghese, I appreciate you giving us a couple of seconds to try to sit with this. This has been a long year, so it's hard to say, but in brief, this is highly concerning. And you would say that. I just think it's also important to echo that briefly. That's my comment. We're all eager to get to the light at the end of the tunnel, but we're not there yet. And between now and then, we have a lot of infections that we risk. I have two questions that may come later. So if you are going to get to these, then certainly let's go with your presentation. But it's about the age, whether we've seen outbreaks in facilities. I think that information is now public, and because of course, senior facilities are high risk. So whether we have some outbreaks, if you have a sense of the numbers there. And then I think the last time we talked, the age of our cases had sort of skewed somewhat younger, but not exclusively so. So are those two things you'll get to later, or do you want to touch on them now?
I will be happy to touch on them now. This was the entire purpose, to have some dialogue. So obviously, as cases in the community rise, the pressure on facilities, especially that are residential, will increase. It doesn't mean there has to be transmission, but obviously if the communities in which they are have more infection, the pressure grows as people come into the facilities, and it's not necessarily through any fault of their own. It's just, when you have this much, we've got human beings in the system. So we have across the region, including Arlington, have seen more outbreaks in these facilities. What we haven't seen is as much affecting, say, the residents per se in all of these facilities yet. Doesn't mean there hasn't been. And obviously the same risk profile for some of these facilities remain. However, hopefully one of the differences, I almost feared saying it, is that I might jinxing it. We've been working with these facilities and they've been trying very hard to have improved infection control. And we continue to send teams out to observe these things in the long-term care facilities. However, as this continues, this will be one of the concerns, will be what will be the outcomes for those residents. So we should not take the lack of significant increases as a sign that it won't happen. We need to be vigilant. We believe those facilities are, but this is why the more we as people in our communities can do the same mitigation strategies, it helps to reduce the load that's in and around us. So there is that, and I think I forgot your second question. So,
well, it's just it could also wait. It's about the age of the cases that we've seen more recently.
So the age of the community, we've seeing this rise in all age groups. And so this time I chose not to present the rate, because while the rate tells you maybe which groups may be more at risk, this is really an issue of what's the burden in our community. This is the absolute number that we're aware of, and the burden is rising. And so that's the way that sometimes risk and burden are two things that people need to think about, because you may not be at risk, but remember, that's a population statistic. Every one of us is at risk from having illness and complications. It's just that some are at more risk, but we have had young people have severe disease in Arlington and in the region and in the state and in the nation and the globe. So that's why people need to remember, while their risk individually may be lower than others, it doesn't mean they're not at risk. And so we need to remind ourselves that we're as much at risk in some ways, and that's why preventing this and not having herd immunity through natural infection is why we're trying to move towards a vaccination program.
Thank you.
Thank you. Mr. Dorsey.
Thank you, Madam Chair. So Dr. Varghese, you alluded to these numbers being consistent with the growth in cases regionally. Can you speak a little bit more as to whether Arlington is driving up that regional average, or we're right about the same? And that'll lead to a follow-up question.
Sure. All I can say is that what we've looked at is that are we roughly consistent throughout the region? There are times when maybe we were leading things, and there are times when others are now ahead. We don't have any reason to believe that we're disproportionately having something that's happening, but I can only say that with the level of information we have. And so that's the only caveat. There was a time when we were leading Northern Virginia. However, other jurisdictions have passed us at times, so I can't tell you why specifically, but we have human beings involved and congregation can happen. That's my gut instinct is obviously it's how we congregate and associate with each other outside of our home bubbles. And we know we've had some of that happening of late.
Thank you. And you and other experts had warned that the fall would cause a significant strain. To what extent are the levels that we're seeing, not necessarily in absolute terms, but just in terms of the slope of the curve, is this consistent with what you expected and feared and warned us about?
I'm trying to find the right way to answer that question. Obviously, it's speculation, but in some ways, but I think what we've seen from all communicable diseases, and especially this one, when you have people congregating, transmission occurs more. And we've seen more COVID fatigue. So I would leave it that those are probably some of the driving forces here. And obviously, there could be increased testing and we're detecting things, and some people may not be congregating as often, but you don't spontaneously get the virus without getting it from someone else at some point. So the gut instinct would be there is, of course, gathering. It's why we talk about community transmission. You can't find the source. And so it can be the incidental contact that you aren't aware of that could be doing this. And so obviously, we would like to open up society, our education and economy. We need the community's help to reduce the burden out there so that all of those other things can happen. It's how are we going to have that right balance? And so this is once again a reminder why the governor took the steps by issuing the executive order to reduce the number of people congregating from 250 to 25.
Thank you.
Dr. Varghese, I had a couple of questions. It could be that neither of them can you really answer or want to answer. One of them is when this all started, we're looking at large gatherings of people, and I've read and heard recently over the last couple of months that more and more the concern is it's actually smaller family groups. So it's like two families maybe decide they're going to get together for Thanksgiving or what, and people aren't quite as careful in those smaller groups, and that's actually where it's spreading more than in going out to a sporting event or a store or something like that. Do you care to comment on that?
So I think that's a very good thing, Madam Chair, to have the opportunity to talk about. When Ms. Crystal raised kind of the settings where people had exposures, they were probably more on the smaller scale rather than the larger scale. So it's just that I think we have to look at it as a both and. When you interact with people outside of your home bubble, you are basically taking on the risk of those other home bubbles and the activities those other small groups are doing. So if you believe, oh, well, I'm sure that they are doing all of the things I am, well, you're only as good as those assumptions are. So I think that's the logic we have to remind people wherever they go. When they continue to go outside of their home bubble, they're interacting with other people's home bubbles and the risks that they're willing to take. So I would say it's a both and rather than it's a 250 person versus a 25 person, because we didn't say that they can't actually be, he didn't say they had to be related people of those 25 in certain settings. So you're bringing your home bubbles together. And if you say you're staying apart, how good are you really doing those things? Are you actually doing 6 foot distances where it's appropriate? Are you actually in a place where the more you are inside, even if it's excellent ventilation, if you have more people together, the pressure for transmission will be greater than if you're outside. So, which is why if you can remain with your own home bubble, whoever you live with, that becomes your social group, and making sure that they're also adhering to the behaviors when they leave the house, because those mitigation strategies, and I'm going to get to those for the businesses as well, are important if they want to be able to stay open and not be affected by transmission or outbreaks in their settings.
Thank you. And I think I'm going to just say that even just a different way, because, I found Thanksgiving. So I get together, I've got my family here. They're kind of my bubble and they're kind of in a bubble, but I know I got grandkids who are teenagers and they got friends and their families all have bubbles, but pretty soon it's bubble, a bubble, a bubble, a bubble. And all it takes is one person in one of those bubbles to not follow it, and only one particular time. And so I think you tend to feel very comfortable in your bubble, but you've got to realize the weakest link in your bubble is what you've got to worry about. So even if everybody's good about it, you got one person that makes a difference. That kind of blows the whole sense of security with your bubble. So people do need to be careful. And I can totally see why psychologically you feel comfortable, but maybe you shouldn't feel as comfortable as we are inclined to do. Thank you. Another question, which you probably can't answer, and this is maybe not even crucial. It's probably something that's going to come out much, much later. I read sometimes about different strains of viruses, so that they could tell that this country didn't come to us from China, it came from Europe. Are we doing when we're doing the contact tracing, is that anything we're sort of following? Because I'm sort of wondering, like this latest bump up, is that like from a different strain that's come in or something? And I'm suspecting you don't know, but I thought I would just ask.
Sure. That is not what we do with contact tracing, Madam Chair. We are looking just to see where they may have been interacting, to identify if there's a possible common source person that would be the outbreak. The type of thing that you're looking for would be actually looking at connecting that information with actually laboratory information to actually see the specific strains. Is there something different about the Arlington strain? I hate even saying it that way. I don't believe that's the case. But if we saw something, are there ways to detect that? That is not something any of the local health departments here have the capacity to do. And right now we're really focused on just trying to reduce spread by this messaging.
Thank you. Yeah, I suspected that was the case. I'm not sure an Arlington spread, but there's something different now that is causing
or Arlington strain. I mean, just for a better term, and I don't believe that's the case.
Yeah, thank you. All right, I think we're ready to move on. Thank you.
Okay. Thank you for those questions. Kendra, would you mind going to the next slide? So let me tell you what we're doing with case and contact investigation in the perspective that we just had of how sobering how much we're seeing. So given the increase in cases in the nation, CDC issued new guidelines for when there are substantial levels of COVID-19 in the community, and the state and local health departments have to prioritize contact tracing efforts. As I mentioned before, we did something similar in April and May when it got to that level. So the Virginia Department of Health recently announced, because of substantial levels of COVID-19 community transmission in the state, local health departments like Arlington may need to prioritize contact tracing efforts for key elements of the population. During this time of significantly high case volume, traditional methods of contact tracing would be less effective because we may not be able to complete it all. So that's why triaging is important. So this means essentially that we may not be contacting everyone with COVID-19 infection, which then means we wouldn't be getting to all close contacts to someone with infection until a time we see a reduction in these significantly high case volumes. So the CDC put out guidelines, and VDH is using them to prioritize follow-up of cases and tracing of those close contacts of those cases. If we are pushed, it would be people diagnosed with COVID-19 in the past 6 days and their household contacts. And that goes to Mr. Karantonis' point of that graph earlier. There may be a lag in when the lab was ordered and when we receive the lab back. So if, let's say 6 days have passed or more 10 days have passed, we're not going to do follow-up at that point because the juice would not be worth the squeeze to be able to change people's behaviors and have them stay home. Obviously, we'd be prioritizing people living or working in or visiting congregate living facilities. We would be prioritizing people involved in known clusters or outbreaks and people at increased risk of severe illness or being in settings. So if they're a healthcare worker and we know that, we would be following up with those individuals. So just as a reminder, as cases of COVID-19 increase across the Commonwealth, this change will allow us to deploy resources where they will have the most impact. This is why we're urging residents to continue to follow the public health guidance on wearing masks, physical distancing, and to notify their circle of friends and family quickly if diagnosed with COVID-19. It's one of the ways to help with this effort to get the information out to people to say, look, we need you to stay home. As a reminder, it's still important to answer the phone if an Arlington contact tracer calls. All of these things will help us to reduce the burden here in Arlington. So I don't think we still believe that case investigation and contact tracing are essential activities. Unfortunately, as you know, if it gets to be so high, we have to triage because there isn't just a cadre of people that we can just keep bringing on. Having said that, we have been hiring more case investigators and contact tracers. We also, and thanks to our county manager, Mark Schwartz, we requested from other parts of the county workforce more staff to assist with these activities so that we have even further flexibility. And our colleagues in the county have stepped up, and we're very grateful to be part of such an integrated system. This is not always an option for the other health departments. Being part of an integrated, locally administered health department, we can actually use county staff in this system, whereas other parts of the state don't have that ability. So we will continue to rely on contact tracing, and we'll do it the new way as we need to, and then hopefully as the numbers come down, we'll be able to resume where we're going. So we'll resume the more robust case and contact investigation fully once the numbers fall. And at this point, I was going to end that section and see if you had any questions about this information.
Great, thank you. Very interesting. Colleagues, questions? All right, Mr. Dorsey.
Less of a question, Madam Chair, and more of a comment. It seems that taken together, the new paradigm for contact tracing and the spread within the community, your guidance from the spring just rings even more true today, Dr. Varghese, that we should just really assume levels of positivity that are out there and behave accordingly. There should be no assumptions that people that we may come in contact with outside of our own immediate family bubble are in any way free from this virus. The assumption should be, quite frankly, that everyone that we come in contact with is positive. Is that fair to say?
Yes. I basically stand by what I've been saying throughout this, but thank you for the opportunity to raise it again. We need to remember that assume that everyone is at least asymptomatically infected, which means that is why you need to keep your distances and so on. So obviously it's not always possible. We have to balance these things in that respect. You know, families have to make decisions about the levels of risk they're taking. Businesses make the same decisions. But as these numbers increase, the pressure on the healthcare system, and it's not just beds, okay? That's what I think some people sometimes fixate on, saying, well, we may not have enough hospital beds. Think about it this way. While it hasn't happened here and we're fortunate, it doesn't mean it couldn't happen where you've got staffing issues because remember, staff live in the community of the healthcare system, so they're going to have those pressures of contact. And then obviously if they're working in hospitals where there's obviously going to be the higher concentration of COVID cases, they may actually run into more. And even if they're doing everything perfectly well, you can have slip-ups. So that is why when we talk about flattening the curve to help the healthcare system, it's not just the physical infrastructure we're dealing with. We can't operate ventilators or ICUs or hang IV bags without human beings in the system. So while we've been fortunately able to meet that, respond to the current levels, which is fantastic, we want to remain in that ability and not ever get close to that. So we have the capacity. We have not heard of anyone in the region having that difficulty with staffing, but we have heard about it elsewhere. And obviously we can't say that we are in so much of a bubble that what happens here is different from other places. We just want to make sure that we preserve the capacity so that we don't have to even deal with that as an option.
All right. Thank you. Mr. Karantonis.
Thank you, Madam Chair. Following up to Mr. Dorsey's question, Dr. Verghese. So the curve before in these 4 weeks from week 46 to now, from week 49, this was the highest single increase. You know, the two from 46 to 47 and then from 48 to 49. And the only way I can explain that is that we have, a bigger spread in community. And you already are talking now about, prioritizing trace. Is there a point? And the fact that this curve is so steep means that the next one, most probably, given the epidemiological progression of this, will be even steeper. Or at least we have to assume that it will be steeper. Is there a point where tracing becomes absolutely impossible?
So with the tracing, obviously we're going to continue to prioritize, and there will be certain settings that we will continue until, God forbid, if every living situation has an outbreak, we will maybe only focus on that. But what I'm appealing to remind people is this, I think, is a way of saying to people, we know at a minimum there's at least this much asymptomatic infection. So can we get people to make sure that they are limiting their exposures to only their home bubble and truly essential activities of daily living, so realizing not everyone has the same abilities. So if you're a essential worker having to work outside of the home, those individuals do not have a choice. So they need to do what they're going to do. But those of us who can make it easier on those individuals by not exposing them as well are things that we need to think about. So could it go up higher? That is what I'm always going to assume, Mr. Karantonis. However, what I'm appealing for, and I think what you all are doing as well, is reminding people we actually can control the level of spread. I have talked about testing. This could be that people, were proactively being tested when they were traveling or about to travel, so they could have detected their own activities, and I want to, or curtail their activities once they discovered they were positive. A thing that I want to report: when our staff had done the testing at the Arlington Mill site, when they got the test results on the Wednesday before Thanksgiving, they made sure that they called all of those people late into the night when they could have said no, to make sure that people had the right information to make the right decisions, hopefully, on Thanksgiving Day about where they're going to associate with other people, because we can't assume why people are getting tested. Some people were doing it, I'm sure, for travel purposes. And as we've said, people have choice right now. I'm hoping they'll choose the mitigation strategies and to stay home. It'll be one way to help reduce this, because as these numbers go up, then we will see a rise in what's happening in the hospitals. And we have seen it, not as high as it was before. And that's good. And it's probably because they're a younger group of people and will do better. But I don't want to figure out and play a game of chicken to figure out how high can we go before there is a problem with our healthcare system.
Right.
Dr. Verghese, I would ask you about whether using an app, etc., is still a valid recommendation, but it can be answered later.
Okay.
All right. I think we're ready for quarantine time frame. That's been changing lately.
Yes. So let me explain. So recently, the CDC issued additional modifications to the usual quarantine period of 14 days. First and foremost, I need to remind everyone listening that CDC and DDH continue to recommend a quarantine period of 14 days. because that's the incubation period of the virus. That knowledge has not changed until they have evidence that it's not 2 to 14 days. The safest thing to prevent spread to other people is to pay attention to those 14 days. So you can then ask, I'll get into the reasons why, but first, what they did was essentially they looked at a shorter quarantine period. It's balancing the reduced burden, or balancing the burden of not being able to go to work, for example, against the possibility of spreading more virus. And the level of virus based on population they're able to put together, as we understand, it's days 5 to 7 where the incubation period or the virus seems to peak, and then shedding goes down. So obviously, as you get closer to each day to day 14, it's going to be getting less. So the risk is reduced, but it hasn't gone away. So what they've done is actually had 2 options for shortened quarantine. So for people without symptoms to end quarantine after day 10 without any testing, or for people without symptoms to end quarantine after day 7 with a negative PCR or negative antigen test performed on or after day 5. And hopefully you have the test result before you're pulling yourself out of that quarantine. If you choose those as the general public, it is still important to watch for symptoms of COVID-19 until 14 days after that exposure, and to continue those always the prevention measures of wearing a mask, distancing, and frequent hand washing. So I talked about reasons. The 2 primary reasons that the CDC has articulated for doing this: reducing the length of quarantine may make it easier for people to quarantine by reducing the time they cannot work. Because we have talked about it has impacts on people's lives on this. And if the risk is lower, it's a reasonable thing for people to think about. Because, if you're the one who can't make ends meet and no one's going to give you money, what do you do? A shorter quarantine period, in one sense, also lessens the stress on the public health system. As you can see, when we've got this many cases, if we don't have to do certain, 4 days of follow-up, that could actually have a significant impact on our already stretched resources. Now, one of the caveats, these additional options apply to all groups except healthcare workers or healthcare facilities. Because remember, those risks are still there, and we want to be the most conservative. CDC's healthcare-associated infection prevention and control experts are currently reviewing the revised guidance. And so until that recommendation changes, we're all taking the stance in the healthcare settings, and that applies even to our EMS folks, that they do the full 14 days of incubation. And if they need to be brought in, then they'll be wearing appropriate PPE if that happens. So I want to make one other point on this, and so we also recommend that workplaces think through the implications of using the shorter quarantine period. While the burden of the number of days not working is reduced, it must be balanced against that small possibility of continued spread for the remaining 4 days without strict adherence to the mitigation measures many people are now quite familiar with. Why am I emphasizing this? If exposures and illness occur in that time frame, how will this impact your ability for continued business operations? We want businesses to succeed in the short and long term. However, I don't think there's a single business, relatively speaking, that doesn't rely on their human capital, their personnel. Those are human bodies, and if they're not there because they're under quarantine or isolation, you can't get your work done. So what's the right balance? And so, Kendra, if you can go to the next slide, it's related to this. I want to remind people to make sure your organization can implement the following 5 key mitigation strategies consistently and correctly, because the consistent and correct use of masks, social distancing to the largest extent possible, hand hygiene and respiratory etiquette, cleaning and disinfection, And even though it says contact tracing in collaboration with your local health department, if there's evidence of an outbreak, please work with us because we want to learn why it's happening in your setting, that there's actual transmission in your setting. Just because there's an exposure doesn't mean there's transmission, but if we determine there's transmission, that's what qualifies as an outbreak. So if you're getting tired of my message, I hope not. It's that consistent and correct use of these sorts of measures that will help in all settings for us to reduce the exposure risk. So, and by doing this, it reduces the risk of exposure regardless of how much transmission is going on in the external community outside of your organization. And I plead with you to remember, our community is not just Arlington. It is the National Capital Region. Germs do not respect geographic boundaries. Our employees come from all over. People seek out all sorts of things across the National Capital Region. And so we need to remember that is why we talk about that, even if your organizations may be very Arlington-centric. So I'm going to stop there and see if there are any questions at this point.
Any more questions, colleagues? We might be ready to move on to the next section. Okay. We certainly can come back with questions, obviously. Okay. Too.
So fortunately, I get to take a break, and we're going to switch over to Dr. Miller. So
I'm glad you get a break.
And then we'll go on to vaccines when he's done. So Dr. Miller, take it away.
Sure. Good afternoon, Madam Chair. Good afternoon, members of the board. Thank you for having me this afternoon, and happy to help my colleague, Dr. Varghese, take a little bit of a break. I'm going to share my screen with you. And I am going to go over, as was mentioned, let's see, there it is, testing and the current state of testing within Arlington County. I'm going to cover three main topics for us today. The first is current testing situation, so giving you a snapshot of what is happening within Arlington County, where we can find more information on that. The second thing is go over information on where you can get a test if you're a resident of Arlington County, and in fact, resources for anybody within the National Capital Region, wherever you may find yourself as you live, work, worship, or carry out your activities. As Dr. Varghese noted, we recognize that it is a very porous region. So we've got that information posted. And then the third thing that I want to talk to you about is what we're doing to meet the increase in demand for testing. So as you've discussed with Dr. Varghese, the increase in cases has led to an increase in folks seeking tests for COVID. And so we've got a number of resources. This afternoon, I want to walk you through and just remind everyone, even though it has been a long 10 months or so that we continue to repeat this, we always have new folks that tune into us. And I always think it's a good reminder with as much information as we have discussed to point folks directly to the primary sources so that they can continue to stay informed, stay safe, and stay up to date. So what I've got for you right now on the screen is the Virginia Department of Health testing dashboard, easily accessible by visiting vdh.virginia.gov. And you can sort by locality. And so within here, we'll sort by Arlington to get a live look. And you'll notice the first thing that I want to talk about, 3 separate types of testing listed. So you may remember that one of the things we've talked about to date is PCR tests. That's the polymerase chain reaction. That is the laboratory test that looks for viral DNA that is generally accomplished by a nasal swab, by a saliva sample, or some other sample collection, which then goes to a lab and is considered to be the, quote, gold standard of viral detection for individuals who are looking for an answer, right? So that is separated out. Then you'll see antibody testing, right? Antibody testing is, well, I'll back up, right? So remember, an antibody is a protein that is produced by the body, and that blood protein is in specific answer to a pathogen. So they're very specific, right? Our antibodies are specific based upon viruses or other pathogens within the body. And so that type of test, that antibody test, is generally accomplished through a blood draw. So you'll have that done by a phlebotomist in a doctor's office or at a lab setting. And they're looking for that protein, right? So they're looking for your body's response to the virus. So it generally doesn't indicate an active infection, right? At that point, your body has produced the proteins and has the adaptive, what we call adaptive immunity, right? The learned immunity to a virus or other pathogen. And then the third thing you'll see, which is new, these are antigen tests. Antigens are molecules that are on the surfaces of pathogens, like viruses, and they are little signal receptors, right? Those little signal receptors are what create in our body, or what our body uses to create antibodies. And so it is a rapid way of identifying that you may have the virus. It has different sensitivities and specificities than the PCR tests. As a result of this, what we like to do is separate out those test methods so that we can use each one of those data points as different pieces of information in the epidemiological picture, so to speak, of what the community has. So right now, I'm just going to focus on PCR tests because it's generally what people think about when they think about going to get a COVID test. So you'll notice a couple of things. First of all, that we've broken 100,000 tests total conducted within Arlington County PCR tests. Now that is across all sources, public and private. You also notice that the rolling 7-day positivity rate, the TPR, which is a number that many of us have become familiar with, is up. That is indicative that, yes, we are seeing more positive tests as a proportion of our tests conducted. You'll also notice on this graph that you can select by day. And so you can see, for instance, on the day of 11/23, we had over 1,500 tests reported to the Virginia Department of Health across all sources. And you can see that demand continues to remain high. That lately we've been averaging anywhere in the 900, 750, 800 range. And you can see how that demand has ramped up throughout the pandemic. The other thing that I'll have you note is this information, while it is contained in the Virginia Department of Health website, is also easily accessible at the Arlington County COVID dashboard. So if you visit the Arlington homepage, the quick link right there at the top, COVID response and testing info, you can then click on the dashboard. And this dashboard brings together all of the Arlington County specific data in one place. Once again, click on PCR testing, and it'll give you that basic information that I just went over on the types of tests and what is shown within this graph. Important to know, obviously, make sure you're looking at the right thing and picking the right piece of data that you're looking for. So once again, you can see our test positivity up just a little bit over the past couple of weeks as we continue to offer wide variety of testing services within the county. So the second thing that I wanted to talk to you about was where to get tested. And conveniently enough, that link is right here. You can click Get Tested for COVID-19 directly from the dashboard. What you're going to see is some information on the left about the different types of tests, as well as a downloadable PDF of the current viral and antigen and antibody test locations. We've provided that facility name, phone number, test type, eligibility requirements, all of the common questions that we get, including language access, whether or not you have to pay if there's an upfront cost, all of the questions that, that folks may have. We've done our best to provide that in the languages that we see throughout the Arlington community. So you'll notice we have Amharic, Arabic, Chinese, Korean, and so forth. We've also put other Virginia locations, Maryland locations, and DC locations. As Dr. Verghese recognized, we need to be able to provide our community with that information. So we've got that all in one place. The other thing we've got is, and we've seen this, an increase in the number of at-home tests. And I preloaded this so that way we wouldn't have to, you wouldn't have to sit through my screen loading. But you'll see the table right here. And once again, we've provided collection methods, the advertised time for results. We know that that's particularly important to some people, as well as the out-of-pocket cost. You'll notice some of them have an out-of-pocket cost. Some of them do bill insurance directly, and for many of them, you'll have to visit each one of those to discuss ways in which you can pay out of pocket, submit for reimbursement, work with your insurance company, should you have insurance. One of the other things that we've noticed is, despite the increase in availability from testing, not only from our private providers, so our urgent cares or our pharmacies, but also our home test providers, we still have what I would consider to be, continuing demand for testing. We are currently in the final stages of expanding testing opportunities, specifically in the 04 and 06 zip codes, through bringing on another local lab company. What we're going to be able to do is offer additional expanded county testing capacity through this at 2 to 3 locations in the 04, 06 area to meet the demand that we see within particularly those zip codes and at our sites that we've have at the Arlington Mills Center, as well as the North Quincy Drive-Through Center. We're hoping to do that before the winter holidays, so hopefully in the next week or two we should see things come online, and we expect to keep that online throughout the winter to be able to meet the demand that we see within the community. So very pleased that that's going to be able to take place and that we're going to be able to help provide the community more options. So the third thing that I mentioned was, and that was a good segue for myself, was what we're going to do to meet the demand that we see now that we're at record levels of requests for tests and people utilizing testing opportunities. So as I mentioned, we've got the 04, 06 zip code concentration and expansion of availability that we're implementing. The second thing we've done is we've expanded the hours at the Arlington Mill site. So you may remember a number of weeks ago, we added on some Saturday time, as well as some expanded hours on Mondays. So what we've now done as well is open up every day an hour earlier. So new hours effective as of last week, Monday through Friday, noon to 5. The second and fourth Monday of each month, we add an extra 2 hours on that, so that's noon to 7. And then the first Saturday of every month, 10 to 2. So that is going to help us, we think, meet some of the expanded demand that's happening there. Two other things that we're doing is, you as well may have heard about the governor's effort to bring rapid antigen tests to the county. We did recently receive allotments of those rapid antigen tests, which allow sort of a quick snapshot in what we call a point prevalence survey manner at long-term care facilities and other locations. We've been able to confirm that the long-term care facilities have received some of those, have utilized them to be able to quickly check the entire long-term care facility population, as well as the workers there for any outbreak status. And those resources continue to remain available as we do outbreak investigations. Coupled with PCR tests, they do provide us with quick, accurate, and extremely important and timely test results to be able to get on top of any potential outbreaks. And then finally, as we continue to look through this, as I mentioned, the expansion of testing capacity in 04 and 06, what we're doing there is actually selecting a different lab provider. So we're making sure we're picking a lab that has extra capacity for us to be able to make sure people can get their test results in a timely manner. We're looking for a variety of methods, right? We know that sometimes the nasal swab is a barrier to people getting a test. And so we continue to implement the saliva-based tests where possible. And then accessibility is the other thing, right? We're concentrating our locations in those areas on places that you can easily walk to, places that are familiar within the community. We're looking at things like community centers and other locations that are critical and key points for our community and that they're comfortable and familiar with. And we're going to continue to do that so that we can ensure everyone has access to a test should they desire.
Thank you. Time for questions now? Is this a good time for questions?
Yes, sir.
All right. Colleagues, questions? I don't see any for a minute. I'll just start
Madam Chair, I was just going to say I'm especially keen to get into the part of the conversation about the vaccine distribution, but I hope that the lack of questions is not indicated, does not indicate a lack of interest in this.
No. I don't think anybody thinks that, and I'll try not to.
Especially to reach our highest need population and to do.
It's great. One of the questions I had, Dr. Miller, it's actually just sort of a general. Could you talk a little bit more about testing in our schools and how you're working with the schools? Because we hear a certain number, a certain amount about that. And I think that there are a lot of people interested in that particular community.
Sure. So I'll start and invite Dr. Varghese to weigh in as well. One of the things that we do in emergency management is we look for best practices in cases across the country. We've been collaborating, for instance, with many of our institutions of higher education, and I use some of our local ones here as an example, to be able to provide some of the information and best practices that we see in those communities to the Arlington Public Schools. We've connected them with some resources on testing, as well as healthcare facilities or healthcare systems that would be open and available to partnering with them for whatever the superintendent chooses to implement. We've also helped them look for the same things that we do, right? Access to contracts, providers that can offer quick turnaround, a variety of services, all of those things. So when we regularly coordinate, we help to provide them that information. Obviously, the school board and the superintendent implement the practices and policies that they feel the best. The other thing that we've done, and I'm happy to advocate for, and thank you all for supporting, was providing the funding directly to the school board so that they could implement a variety of things, right? That included flexibility to implement certain testing procedures, as well as getting the personal protective equipment and other things that they needed in order to be successful.
Happy to provide that support. Thanks for doing it. All right. Any other questions, or should we move on, Mr. Karantonis?
Madam Chair, following up on your question, Dr. Miller, allow me to drill a little bit deeper on this. So is there a test regime? Because there is as you know, there is a reasonable conversation community about when and under which conditions we will be opening again, or we will having in-person instruction, or, phasing into this. Is there a testing regime we have to prepare for? In conversations with school board members, I heard something like, thinking about providing random testing of a certain level. What is the recommendation?
But I'll say in general, and I'll let Dr. Varghese take the second half of this. There are a number of different testing strategies that can be implemented depending upon the administrative design or the operational aspects of the school, and that varies in what they decide to implement, right? For instance, cohorting, different quarantine procedures, right? All of those things impact whatever testing strategy could help support it. Testing is not the end-all be-all, and is not going to be a panacea to helping get into reopening. It's going to be non-pharmaceutical interventions. It's going to be continuing to observe social distancing, social and physical distancing, mask wearing, as well as good public health, hand hygiene, and those sorts of things. Dr. Varghese?
Sure. So as Dr. Miller indicated, testing is obviously going to be part of anything, especially getting students and teachers back to schools if they've had exposures and are cases and so on. So that'll be part of the usual strategies. Then it's really going to be up to what the comfort level and what the goals are for organizations. So if it makes people feel more comfortable, we know that that's actually something that school systems have pursued throughout the nation, and so could actually adopt a so-called randomized testing scheme where you then decide to randomly test those who've consented to those sorts of activities, to then use that information to figure out, who, are there potential exposures. And then when they get those test results, a school system would work with their local public health department to then do the appropriate follow-up, so that if there are cases, you'd want to do a contact investigation to see where there are exposures, and based on how these things are designed, what the recommendations would be and so on. So it really, there isn't a one-size-fits-all recommendation. It's really going to be what the community is interested in. And as Dr. Miller pointed out, the county has been, I'm grateful that the county has been able to provide resources to the school system for testing to make those decisions. And we are always available to help them interpret the results. And if testing is something that community thinks is the way to go, we just have to remind people that you can't test out of certain things. It's one of the mechanisms to understand what's going on. And as I talked about the mitigation strategies, more than anything else, rather than metrics or anything else, let's make sure that we're doing all of those things in a way that the community, especially the schools community, is most comfortable with. But have to realize we cannot live and assume that there's a risk-free environment outside or even inside. Having said that, we can actually learn to live with the virus if we put the mitigation strategies in place in a way that benefits children. And the thing that we've got to remind people is, while everyone's at risk, children, especially the youngest, are not the primary drivers, based on the evidence so far, of transmission in schools. They are not the group that actually is likely to have infection. Not that they don't get it, but they're often the least likely at the youngest ages, and their ability to transmit to others, either to other children or to adults, is less, not zero, but it's actually adults that are more likely to transmit. And so that's why it's kind of like, if the mitigation strategies are in place, it helps to reduce the transmission risk. And so that is one of the things that we have to actually keep in mind is, what's the level of risk? And then how do you balance that with the other risks from not having schools open? There are public health reasons there as well. So just that's going to be, I wish there was an environment that it was 0% risk for all of our activities. We just don't have that. So what we've got to figure out is a way to figure out, and the schools are determining what the right level for everyone, because we can't get to have one group have 0 risk and the other one has 100%. Hopefully we can get to a place where the community is comfortable with that it's a 70% and you mitigate those risks. I came up with that number out of my head. Please don't quote me that it is 70%, but it's as an example. If you can get to 70% and reduce the risk based on that, how do we create the environment that we can get people back in and do this? Because we've got to learn how to live with the virus. But that's going to be a community decision, because that's a values decision, not a science-based decision.
Thank you, Dr. Varghese.
Yeah, thank you, Dr. Varghese. And I think the schools are working on how to do it, and can people calibrate depending on their own personal situations, which I think is important in something like this. Mr. DiFranti.
Thank you, Madam Chair. I really appreciate your question on the schools, and I'm also eager to get to vaccines, but I couldn't let this go without a big, I'm so looking forward to the next the 2 or 3 locations, and I know it's been a lot of work, Dr. Miller, so just a thank you for that. Using a different lab provider seems wise to me. Expanding Arlington Mills seems wise to me. So you're sort of toiling in the middle of a very difficult time. It feels like a marathon at a sprint's pace, but just want to particularly thank you for continuing to work on getting us additional testing locations, because it's super important. So thank you.
Thank you, Mr. DiFranti. And I'll just add how much I appreciate the targeting you've done, figuring where the most vulnerable, where do we really need to target the testing, and doing that. That's great. Thank you. All right, I think we're maybe ready for the next section.
Kendra, if you could put the slide deck back up. Okay. Could you advance it one more? I think, yes. Okay, so we're on the vaccines, and the highlighted areas in blue are what I'm going to first focus on. And my apologies to the viewing public and to the board members that you're going to hear me talk a bit more. So, but you've had a break. So
it's just fine, Dr. Varghese. You're doing great.
Okay. Let me give you some general comments about COVID-19 vaccination, kind of to set some of the stage. And as our county manager said, there are going to be a lot of things we don't know. So I'm going to try to provide what we definitely know and what we at least believe the directions are, with the caveat that things can change and we're going to have to be flexible because the nation's never done this before, let alone Arlington. So many people are anticipating the arrival of a vaccine for COVID-19, which is the hope here. Having a safe and effective vaccine is also the top priority for vaccines in general and for what we're looking in public health to be able to provide. Details are still being determined, and here is what we currently know, or what I currently know about the COVID-19 vaccines. Obviously, we know several vaccines are in development. What I can say for certain is 2 will be undergoing FDA review in the next 2 weeks. In fact, the Pfizer vaccine is supposed to be reviewed on December 10th, which I believe is Thursday, and then the following Thursday is the Moderna vaccine. So it is actually possible that vaccines could be ready in December for some groups. This will, of course, depend on what is learned from these studies and the FDA rulings. Even though you'll have heard that production has been going on, and I'll show you a graphic eventually, if they say it's not safe or effective, those vaccines will not be made available. Currently, a vaccine remains only one of the ways, and this is an important thing, one of the ways to stop the spread of the disease. Remember, especially with the supply of vaccine being limited at first, continuing to do the other things to help stop the spread will be just as important as it is now, which means, once again, wearing a face covering, staying at least 6 feet away from others, washing your hands a lot, and staying home if you're sick. So moving on to the topic of why we need a vaccine, just to remind everyone, getting vaccinated against COVID-19, we believe, if it's effective and safe, will be one of the best ways to protect yourself and everyone around you. If you're protected from getting COVID-19, you are less likely to pass the disease to others, or the germ. The more people who get vaccinated against COVID-19, the better it is for everyone. More people vaccinated with a safe and effective vaccine means that there will be less germ spread and disease in our region. That is the hope. So getting vaccinated is one of the most important steps to protect yourself and your community. And by stopping the spread of COVID-19 with vaccine, it gets us closer to the end of the pandemic when it's effective, so we can have our businesses and schools and other venues, our society, open as usual without COVID fear. So people often hear about vaccination and herd immunity, so I thought I would take a few minutes to talk about that. Vaccination is necessary if the goal is for herd immunity. And herd immunity is our way of saying when most people in a population or group are immune to a disease. Being immune means they cannot get the disease because they either got a vaccine or they already had the disease and can't get it again, at least for a while. When a lot of people cannot get the disease, it helps to protect other people in the population who are not immune, and that means they could still get the disease. Herd immunity may stop or slow the spread. What we have to know is we don't know enough about COVID-19 to be sure that herd immunity is possible. This is a new disease, so obviously we've had essentially about a year's time with the disease. So obviously there's no way we can buy that time in advance. So some of the things we don't know, which affects this, is how long a person cannot get sick again after they already were sick with COVID-19. Said a different way, how long are they immune? If being infected before will make the next infection better or worse. If a person who was sick before and then has contact with COVID-19 again, will they be able to pass the virus to others? However, the reason why we focus on herd immunity is we don't recommend letting herd immunity happen naturally, because this can come at the cost of others possibly getting very sick and dying. Vaccination in the past has been a way to reach herd immunity without people getting sick and or dying. So that is the goal of vaccination. And it really lets a person's body develop the protection against a disease without having to actually get as sick with the disease as you can if you are exposed to the virus. So, moving on to vaccine safety and efficacy, let me move on to the next slide. I'm sorry for you all having to look at it at that level of detail. It's tiny, but what I wanted to be able to show to people is there is a usual process for the vaccine development process, and that's where it says the pre-COVID vaccine development process, and the sources for this information are CDC and FDA. And there are essentially 7 steps. There's a preclinical or laboratory animal research. Phase 2 is smaller safety studies with human beings, then larger trials with human beings or clinical trials. And the largest would be with thousands of folks being getting the vaccine, determining how effective. It would normally go through a licensure process and then monitoring for the production before vaccination begins. And then after vaccination, there would be continued, this has always been the case while I've been practicing, that there is a ongoing post-vaccination safety monitoring to detect what may not have been able to be detected with even the large studies at those points. The COVID vaccine development process is essentially the same that FDA has put out, with a few modifications because of the pandemic. All of the steps are there. The first 4 dealing with the preclinical and the phase 1 through 3 are the same. The approval process is using an emergency use authorization because the recognition is that there's an emergency afoot. You'll see that the production was actually authorized at the same time. Now, what that means, none of that vaccine has actually been released, okay? That is what's being waited for by the FDA process for the 2 subsequent Thursdays. They were simultaneously permitted to make it. That is what the federal government was actually purchasing, was like the ability to have it ready should it be seen effective and safe. If those things are true, then there's no delay in that sequential need for production, because then it leads to further delay. So if it's not approved, those vaccines will not come out. And that's the end of the story as we understand it today. Obviously, this is why we want to hear everything. And then when vaccination begins, the same processes at a minimum will be in place to monitor to see if these things are the case. What I'm looking for, and sometimes people ask, what am I looking for, and my colleagues, we're looking to see how much have these processes been similar, pre-COVID, post-COVID. I don't do assessments based on press releases. I'm just going to use this as an example. If the press releases are borne out by what the FDA reviews are, for example, when you compare the number of people in phase 1, 2, and 3 for the Pfizer and Moderna vaccines, they're on the same par of the number of people that FDA typically recommends for other vaccines. So those who have had the shingles vaccine that was done pre-COVID, those are things that they're aware of. They have similar numbers of people that were tested. So that is why we're looking for the processes to be roughly the same, to be able to make the conclusions about safety and effectiveness. And so that's the general gist of this is, and I can go into more detail as questions come up, but I wanted to first make sure that was said, and then I want to go into, before taking questions, going into a few more things, including what we know about what's going to happen in Virginia, okay? So moving on from this slide, so I'm going to talk about the special populations being tested, because I know that sometimes is something that people want to know about. So based on the public information, and this will be confirmed when the FDA does its reviews, non-pregnant adults ages 18 years and older, to include these specific segments of society, the elderly and those who are racial and ethnic minority groups, are supposed to be part of these trials. I don't have any specifics on that. That is what we're waiting for the FDA review and seeing if they believe there's enough data. These reviews should provide more information, so stay tuned. Groups to be included in future studies: children. I know this is going to surprise people, but this has been a usual practice, is that these types of studies are typically done after it's proven that the vaccine is safe and effective in adults, because the value has been that we are going to protect our most fragile in society, like children, especially if they're not at the greatest risk initially. It makes sense, but I know people are going to be disturbed that it wasn't done at the same time. But this is the standard processes for vaccines. And pregnant women have not been, excuse me, enrolled initially. However, having said, those studies will happen, but obviously they don't know when people enroll in these studies, men and women, if those who are able to get pregnant actually become pregnant during that time frame. So they may have some data, but I'm not promising it yet. So that's what I'm looking for, and my colleagues at the state level are looking for, and in the region. What is the real information about what is known and not known from these studies? And we're talking, these studies have involved between 30 and 40,000 people, and that is about the normal size for these sorts of trials. So where do we stand with vaccine in Virginia and Arlington? So some of you know that the Advisory Committee on Immunization Practices did a prioritization meeting early on December 1st, 2020. And they basically decided to agree with the recommendations from the National Academy of Sciences about prioritizing healthcare personnel and long-term care facility residents. And that fits with their principles, and they're published, so I'm not going to review those. But healthcare personnel, as they defined it, are paid and unpaid persons serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials. And that includes long-term care facility staff. And then the long-term care facility residents are defined as adults who reside in facilities that provide a variety of services, including medical and personal care to persons who are unable to live independently. And that committee's recommendations had to be approved by the CDC director, and it has been done. As I've mentioned, the FDA is having meetings to review the emergency use authorization requests. December 10th is the Pfizer review for its messenger RNA vaccine, and Moderna, it's December 17th, also for its messenger RNA vaccine. And then after those approvals, the ACIP is supposed to meet again. So if FDA approves what are these vaccines, what are the next steps in Virginia and Arlington? I want to remind everyone the Arlington County Public Health Division has another name. It's the Arlington Health District. We're one of the 35 health districts in Virginia under the Virginia Department of Health. So we are going to have the same access, obviously based on whatever our personal characteristics are, makeup of those populations. And they want to remind people the reason why we're vaccinating is because of the very potential of the pandemic as we've seen it in this rise. Virginia is preparing to receive a total estimated 480,000 doses of vaccine from the two manufacturers if they are approved. I don't have the specific ratios at this time. And as a reminder to everyone, the actual amount received is a moving target and dependent on vaccine manufacturer output, but we're getting more confident that's roughly what we should be getting. That with the VDH estimate that there are up to 500,000 healthcare personnel, including the staff at long-term care facilities, as well as the long-term care facility residents in Virginia, means that we should be able to vaccinate the majority of those categories, if all goes well, with their first dose of vaccine in December and January when this stuff all happens. The devil, of course, is in the details. VDH is working with the Virginia Hospital and Healthcare Association, or VHHA, to prepare the health systems that have the ultra cold chain storage ability to receive these first shipments, because it has to be done safely, and you don't want to go through the expense of creating all of this and then not maintain the vaccine at the appropriate temperature, because the mRNA technology, because it's a natural process in the cells and it's not supposed to last very long. The instructions break down, so we don't want that to happen before we're even able to actually provide the vaccine. All of the initial doses will be distributed to various healthcare systems with that capacity, and the plan is that those healthcare personnel that directly care for COVID-19 patients or in support of that will receive top priority first. Let me see what next. We expect the second doses at the appropriate time. For these vaccines, it's the effectiveness data showed that it required 2 doses. So if you have dose on day 1 or day 0, sorry, then one of the vaccines requires immunization again 21 days later, the other 28 days later. And so we expect, based on what we've been told from the federal government, to get the second doses at the appropriate time. And obviously people have this question. So as future weeks bring more deliveries, we expect that there could be overlap in the doses being administered. That is, some getting first doses and others second doses in the same weeks. People will want to know what we as a division, health district, and the county have been doing. In broad strokes, while we've had plans for years for mass vaccination, obviously the wrinkle is incorporating 6-foot distances to those plans. And all of the plans here and elsewhere, we have to build in appointment schedules because you don't want people to congregate in lines and pass germs to each other. So this is something that all states and localities are going to have to deal with. And it's just, I think one of the things we have to remember is this is part of current COVID reality. We've been working on the ultra cold chain storage issues by ordering these for ourselves and our partners who don't have them. And finally, we are working on training on these procedures, including training on the vaccine when that information is finalized by FDA, the manufacturers, and VDH. So a lot of this is significant moving parts, and we need to have those things in place. And so as our county manager, Mark Schwartz, has indicated, we need to be prepared for changing information. I know our community, as everyone else, is anxious to be over with this, and we ask for patience because things will change. And a few last comments on vaccine before letting you ask questions. How much will the COVID vaccine cost? The vaccine itself will not cost anyone anything. These are the miscellaneous points. Providers who can charge to insurance are allowed to do that. VDH is not going to charge that for any of the public clinics that the health districts run. We don't want any barriers, especially for our at-risk populations. And as a reminder, how many doses of COVID vaccine will be needed, and will a booster dose be needed? We don't know for sure yet. We obviously know how many doses are needed for the vaccines coming out. The 2, if they're approved, it would be 2 doses. There is one that would only require 1. However, as time goes on, we will learn whether future doses are needed, like needing a tetanus shot every 10 years. Obviously, we won't know that information because we've only had 4 or 5 months with the studies that they've done. And so I hope people will be reasonable in their thinking about this, that we can't have more information than time is actually allotted for us. With that, I am turning it back to you, Madam Chair.
Thank you, Dr. Varghese. Colleagues, I'll take questions, and I'll ask one real quick while people are thinking. So you get a first dose and a second dose. How important is it that you get it exactly a certain amount of time after the first dose?
Great question.
There must be a range.
Well, I mean, we're waiting for that official word, and that's what we're waiting for on this Thursday and the subsequent Thursday, and whenever they put that information out. So as a general rule, there's probably a little bit of latitude based on other vaccines, but given some of these issues, maybe the rate limiting step will really be the ability to schedule the appointments so that we need people to be flexible, whoever's providing it, if it's the healthcare system or us or other providers. But as a general rule, given that they've made these recommendations, the closer you can get to the times that they're suggesting, we want it to not be wasted doses to be able to have the immune system do what it needs to do. But obviously, that's what we're waiting for with the FDA recommendations on some of those questions.
Great. And I've got more follow-up questions, but I'm going to go to my colleagues for now. Thank you. Ms. Crystal.
Thank you, Madam Chair. Dr. Varghese, thank you for the presentation. I think in recent months, we've all gotten a little more familiar with the logistics and the data sharing when it comes to testing results, for example. It is, I don't want to say a patchwork because that implies it's not working well, but it is certainly a multiplayer partnership, right, between the testing that the county performs, the testing the doctor's offices may be performing. Increasingly, we're seeing pharmacies perform. And my understanding is we're going to sort of see a similar set of relationships emerge around vaccination. I know, for example, I listened to Dr. Fauci on the news saying the other day, you'll be able to walk into a CVS or Walgreens and get the vaccine. He had said by April, like from his lips to God's ears, right? Can you talk to me a little bit about the Arlington Health District, as you were saying, role in collecting, coordinating, working on that information so that we, is it even possible that we can get a full picture of what % of our community has been vaccinated, even though surely we, as Arlington County Health District, will only be actually doing the vaccination for some fraction of our residents?
No, I think it's a very good question, Ms. Crystal. The systems are there, but they are patchwork across the nation. Having said that, it all depends on which systems have electronic health records when they're entering it and their ability to then have that dump into the larger systems at the state level and then the state dumping it into the federal level. So it's only as good as that, and we always continue to get more providers enrolled. We will be able to do that for the clinics that we're doing. If our hospital system, for example, is part of it, they will come up with their systems and they have the mechanisms to be able to dump into those things. So it's just that each state has a different system, which is the other issue. And so as we get the information, we'll obviously be trying to figure out how to report that information, but that's probably not my first priority because it's trying to make sure that we've got the clinic set up to be able to provide this information. And since you mentioned CVS and Walgreens, they're actually the two providers that are going to provide vaccine to the long-term care facilities. They are the ones who are, it was a federal program, so they're in charge of basically the logistics for all of the long-term care facilities that did sign up. CVS or Walgreens will be working with those facilities to provide the vaccine to the residents and to the staff. And obviously, this has never been done before on such a scope and scale. So they are also supposed to enter the data into their systems to get it into the state and federal systems. Obviously, we don't know how it's going to work. I trust that it will eventually. As like anything else, we've had some growing pains. We will eventually get to something more smooth, and I ask people to have forbearance because I suspect that we're going to have to help people along in this process and course correct. And our role is to make sure that we can communicate to VDH if there are problems in the field to see if they can, and if there are similar ones elsewhere, how they then work through those situations.
Okay. And so as with test results, VDH is really the fulcrum. Our data is only as good as we can get from VDH. Their data is only as good as they can get from private partners and others.
Correct.
Okay. Thank you.
Mr. Dorsey.
Thank you, Madam Chair. First question, suspect we'll have multiple rounds. Dr. Varghese, when the data is released from FDA, hopefully giving greater fleshing out of the press release data that you reference, will it be disaggregated so that we'll be able to answer key questions such as the degrees of sickness that people who get the vaccine, the rate at which that occurs, but also broken down by race, ethnicity, or maybe other target groups so that we can convey clear and targeted messages to people in the community about appropriately measuring whether or not they should seek out the vaccine when it becomes widely available?
Sure. If things are followed, Mr. Dorsey, as previously done, that information should be made available. Of course, we have to see how many people were in these groups and so on. And then obviously one of the caveats I have to remind people is if they're going to approve it, the likelihood of, if there are serious adverse events that they're worried about, the likelihood is they will not approve it. That's my gut instinct. What people need to remember is it's really, the majority of these things are the temporary side effects that people are going to be faced with. And I think based on what I'm hearing is that there will be some, a day or two of experiencing muscle aches, pain at the site of injection, and possibly fever. So we need to remember that vaccines sometimes have temporary side effects. If there were very large other more permanent side effects, they don't typically, they wouldn't be considered safe and would not be approved. Obviously, there are people who are always concerned, and it's like, well, that's why there's also the post-vaccine surveillance that's done, saying, on the off chance that maybe when you vaccinate 40,000 people and still can't detect something, is it even rarer than that? And that's why the world looks at those things collectively. It wouldn't just be the US surveillance data, it'll be with the UK data, the India data, wherever this eventually gets done. So it's a long-term surveillance at the same time. However, going back to your original question, I would presume if FDA does what it's done before, if it presumes that it's safe, they're going to be doing that on the basis of that there weren't any major adverse bad reactions, but it's temporary things that were detected, which is not unexpected, because if the body's going to react as if it got the actual infection, you would presume that there will be some reaction to something we've never seen before. I hope that helps.
It does. And can I do a brief follow-up in this?
Please do.
Sure, thank you. So when our family does our annual influenza vaccinations, there's a questionnaire that we have to fill out, which not only indicates our basic disease history, but some questions about how we're feeling in the moment. Does this vaccine, from what you know about it, require any sort of prior medical history or current state of wellness check in order to improve its efficacy?
It's a great question. I'm going to use general knowledge, but wait till we hear more from the FDA. Obviously, we need to know. I cannot imagine that they're going to allow people who are currently sick to get it, because you don't want those things. So those may be the types of screening questions, unless they're, if they think that it can be done safely. I'm not going to object. I leave it to the experts on that vaccine. But beyond that, we're going to wait till whatever FDA puts out as what needs to be done by healthcare providers, providing it as the information. And if there are screening questions, I can imagine the traditional screening questions for COVID, kind of like if you're actually ill, I can't imagine they're going to recommend that we vaccinate people and bring them in that sort of way. So I wish I could be more specific, but I should take my own advice and say, we have to wait to get the answers.
Thank you, sir.
Good advice. Mr. DeFranti.
Thank you, Madam Chair. I feel like that last answer is I'm a scientist, which means we really have to, and we have to appreciate you have just been so working so hard for what feels like a long time. On the question of federal, state, and local roles, it sounds like the decision as to how large a group would be provided the initial, healthcare workers, right? There are people who work at a hospital who may not be healthcare workers, and seems like a huge number of decisions that would then come in exactly who would be covered at which stages. Is it fair to basically say that those decisions will play out over time, and there will be a state and local role to them, and that local role would be led by you and our department as our healthcare leaders?
It's a great question. So first of all, just on the healthcare personnel, and I know there was a lot of information I provided, so I'm going to go back to the definition that the ACIP provided. Healthcare personnel are defined as paid and unpaid persons serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials. That's actually a rather broad, generous definition. Having said that, it's going to, the way, as we anticipate in Virginia, the hospital systems in the state are the ones most likely to have the ultra cold chain storage. And they're, of course, also been prioritized by ACIP as the places to keep the healthcare infrastructure, not the physical beds, but as I talked about before, the staffing capacity to help reduce their exposure risk and subsequently getting the illness. So this does not mean it's always going to be doctors and nurses. It can be patient techs as well. And then as that gets done, hopefully we'll be able to then start providing others in the community who fall in that same category. You know, dentists would be at some point in that scheme, home health aides, those sorts of things, groups would be part of that healthcare personnel definition before we talk about any other essential groups. But that's the other thing. ACIP has only at the moment prioritized and told us what the phase 1A criteria are. So before we get to other categories, right now it's really healthcare personnel as broadly defined that way and long-term care facility residents that are going to be in that first round, which trying to make sure that up to 500,000 individuals get their first and second dose is not a small task. And so we want to work through that. But I understand why people want to know and figure out where they're going to be. And one question I'm going to anticipate is, there should be enough doses based on what we're hearing from the federal government. Obviously, that changes based on approvals. But for this sort of process, I have to admit, there are going to be some people who are vaccine hesitant. I hope not. But that also means that perhaps not all 480,000 doses will necessarily be claimed initially. So there may be, we may be entering other groups a little earlier. All of these are the unknowns. And so that's why we're going to try very hard as a state and as a region, as a locality, to ask healthcare workers and long-term care facility residents if they're comfortable to get vaccinated, because we do have confidence that if the data is there, even if it's, say, only for a year that this is effective, that could buy us time to reduce the number of people who have it and who can actually transmit to each other. Because remember, flu vaccine isn't, you get an annual refresher in a sense. So we don't have that experience yet because we've not been able to follow anyone for a length of time. And I hope, as I said before, we need to remind people what's realistic. The study information, if the press release information is true, which I can't imagine they'd do this only to be told that it was a lie. If it's that good, that's a hopeful sign, but we won't know how long it remains effective till we give it and follow people over time.
Great, it's very helpful. I'll have other questions, but thank you you kind of gave an illustration of the challenge, the level of detail and challenge in the communications out of the information that Mr. Schwartz started the session on. So thank you, Madam Chair.
Sure, I'll go to Mr. Karantonis.
Thank you, Madam Chair. Dr. Varghese, just to be sure, the fact that we are going to enter a period where vaccination will be available doesn't mean in any way that all the other precautions for COVID hygiene, are going to be relaxed.
Okay, thank you for that opportunity to clarify that. So what we won't know, partly because of the time, is assuming that the data that was there that shows that it's effective. It is shown that people are able to seem to be at reduced risk of getting like the group that got the vaccine compared to the placebo group, the vaccine group had less illness than those who got placebo. But what we have to find out is how much less. Is it 100%, or is it? These are the details we probably won't know until time passes. Does it mean that you still can't possibly spread it? So is it that you won't get infected, but are you still able to carry it, and could it spread to others? So that is why one of the things that we've been saying even before the vaccine was available, and some of what I already talked about, is we still need people to do all of the behaviors. So if I were to get the vaccine, I would still, after both doses, still be maintaining 6-foot distances, staying within my house bubble as much as possible. Those things, all of those precautions are still needed, because we are trying to not have this as a get out of jail free card, but to get rid of this, sorry for the language, damn virus from our society. So we need continued doing these behaviors correctly so that we can keep increasing how many people are protected and reducing the amount of germ that's in our community and across the globe. Because what we have to realize is we may have access to the vaccine first. For those nations that don't, and let's say we start traveling, guess what? Virus is introduced. And as I've said, we don't know how long it's effective. All of those things are unknown. So that is why people have to remember we're a global economy. It doesn't seem that way, but we're still getting people to travel. And so those are going to be some of the things. We just can't assume we can open everything up. But this is at the same time that living with the virus is an important thing to work with, which is why with or without the vaccine, we need to do all of those mitigation strategies so that we can open up the areas that are the most critical things in our society to allow those things to occur.
So to follow up on this, Dr. Varghese, can you imagine a situation where employers, for example, or airlines would require proof of vaccination?
I am going to leave that to the lawyers out there and the employers' lawyers. I don't know what can be required under the law, and so I'm going to leave that to others to answer. I'm assuming people will presume that they could, but as I said, this is all speculation at this point. I can imagine right now we have voluntary provision. And hopefully, as we show that it's safe when it comes out and effective, hopefully that will be the example that will get people to actually be interested, because it's not going to be me, and I apologize, or any of you who are going to convince the public ultimately. It's the people who may know us, and we keep telling them, and there are other influencers, and if they learn from people that they trust that about their experience, that's why we need to get this message out and help people get the right information so that they can feel more comfortable taking what's best, the right steps for them. See,
Mr. Schwartz.
Yeah, on the question about the employer ability to mandate, I know Mr. McIsaac is with us, and he may want to comment on it. I've had conversations already with, for example, the fire chief and police chief about how we would go about once we receive the vaccine, assuming that we're unable to mandate it, okay? I'm not sure I would be inclined to mandate it, even if we had the authority. But by matter of example, having them and also the heads of the employee organizations simply just roll up their sleeves and show people that they're going to get it done. It would be my hope that most, if not all, of our first responders receive the vaccine. There was a survey done in New York City about the fire department there, and barely 50% of the firefighters said that they would take the vaccine. So I have to tell you that we have some enormous challenges if we're in a voluntary regime. I think that there's been many articles written about providing incentives. It provides another series of difficult public policy issues about should we be providing incentives, and then also, what if we offer a vaccine and someone refuses to take it and then they become sick as an employer, what is our obligation? So I'm going to offer Mr. McIsaac, if he wants to add anything to that. What I've done here is just repeat what I said at the beginning, raise questions and not provide answers.
Thank you, Mr. Schwartz. Mr. McIsaac?
Yeah, Madam Chair, this is a difficult question, and it's fully loaded as Mr. Schwartz was describing. I think that the starting premise from the legal point of view began with the smallpox vaccinations, where the Supreme Court addressed the sort of the balancing that goes on between public health and individual liberties, and concluded that vaccination was a more important outcome than personal liberties. And I would say with something like COVID-19, it's very, very analogous. So the case law may be somewhat favorable. I know there was recent litigation, recent meaning within the last decade or so, regarding, the childhood or, infant vaccinations that many parents have begun to refuse to have administered to their kids. And New York State in particular was instrumental in refusing to allow them to attend public schools. And that was litigated as well. So those are the kind of touchstones we have when we look at this question. I think, though, that, we're getting ahead of ourselves right now as far as having to decide a question of whether we're going to make our employees get vaccinated. I think that the voluntary approach is probably the most desirable one, particularly given that the availability of the vaccine right now is kind of a hypothetical issue. We'll have to see how it rolls out and what the compliance levels are, and then we'd have to make a judgment call about whether to mandate it, understanding, of course, that all of that will occur in the context of providing appropriate accommodations for those who, for different health reasons, can't have it.
Thank you. I just jump in and do a quick follow-up. So, Dr. Verghese, could you talk a little bit about who's keeping track of this? So, who's keeping track when somebody, have you had your vaccine? Or which one did you have? Well, I don't know. Or, yeah, sure, I got my vaccine. And then the employer checks and maybe they haven't, but maybe they can't check. Can they check? Who's keeping track of all of this? Because it's a lot all at once. Is anybody?
So, great question, and it harkens back to Ms. Crystal's question about how the vaccine and the records are going to be available. Right. This is all healthcare information, so that is why healthcare providers are going to be the ones having the primary repository. One of the benefits of the way Virginia works is the vaccine information eventually gets dumped into a central registry, but employers don't necessarily have access to those things. So those are going to be the questions that all employers, including the county, will have to decide how you're going to get access to that sort of information. So that's the most I can say about it, and I defer to Mr. McIsaac for the county specifically.
Yeah, thank you. And but there's even not the employer thing. There's, do you get your second dose, and what's the second dose that you
Sure.
need? Because when did there's so many questions.
So on that respect, sorry if that's the question, obviously they're going to be given a appointment card to return. Obviously, some people will be better at that than others. So certain employers, if you're a hospital system, you, as the provider, would actually know and have maybe a more automated system. Reminder recall systems would hopefully work. All of those questions are still to be determined on what we're going to be able to do, both as a Commonwealth and the various providers in that system. So which is why it's a light at the end of the tunnel or a bright light along the way, but there are so many details that still have to be worked out. I think overall it'll work, and we have to expect there will be bumpiness and some messiness, but what hasn't been somewhat messy about COVID-19 and a pandemic, so.
Yeah, no, exactly. That's why I use that dark forest analogy. Don't begin to be out of it. I'm not sure. Maybe Mr. Dorsey is next, and then Mr. Durante, I think, and then Mr. Carantonis.
Thank you, Madam Chair. And this follows up on your question, which followed up on Ms. Crystal's question from a while ago. So given the limitations on the systems that you identified, and also the lack of widespread availability, at least at the beginning, combined with the lack of a nationwide standard for how this should all be deployed, and that there are multiple brands that may be available at the same time. Like, given all that, Dr. Verghese, I'm curious, is there something that people should know specifically to protect themselves best? Because I imagine there might be innumerable reasons and demand for people to get a vaccine in one place and then want to get the booster in another place. And it seems like with all of those limitations that I prefaced with, it might be best if people planned to pursue their vaccine regimen in one place and at one source. So that's the first question. And then two, on the provider side, are there any protocols that they're thinking about or going to deploy, kind of like the verification systems in hospitals before you get medication, where multiple things are checked, so that they know that when they stick you for the booster, that they're in fact giving you the Pfizer booster and not the Moderna booster, which you should be getting. So
great question, Mr. Dorsey. I would endorse your perspective. The more that people can get their vaccine from the same provider, the better. That would be the recommendation I would say at this moment. And to reassure people, at least based on what I understand, what Virginia is going to be doing and will be done locally in a sense, because we're part of that system, we're focusing on healthcare workers or personnel and the long-term care facilities. And it's the same providers at the moment that are going to have that access to the records of vaccination and so on. So hopefully that's a model to build off of. Obviously, one of the things that we're hearing is that if companies like CVS and Walgreens are going to be part of this system, not only short-term but long-term, then they hopefully will be able to build off of their own record systems to be able to do those things. But that's speculation, so I don't want anyone to base their decisions based on that. We need to hear those details coming out. So I think we're going to have to be patient, but your recommendation of getting it from the same provider would be one way to know what vaccine you get, because you can't mix and match. And that was the point I wanted, you allowed me to raise this. You cannot mix and match between the vaccines. So you can't get like the Moderna vaccine on day 0 and then say, well, I now want to follow up 3 weeks later with Pfizer. There's no evidence that that will be effective. And so you're locked into whatever you're getting. That doesn't mean you shouldn't do it, but we just have to be patient. So I think the safest course for everyone, and you've reminded me, is initially try to stick with that sole provider. And given the fact that there's only so many doses, we're only going to be giving it to certain populations. So I think that's going to be more likely the case in this first phase anyway.
Thank you. Mr. DeFerranti.
Thank you, Madam Chair. Just I wanted to it's not so much a question as trying to, as you describe all these issues, and I'm thinking back to the debates on electronic health records way back to the 90s, mid 90s, when I first was interning and became aware of it. There's a lot of detail, and this form of a work session is certainly very good. It's given me occasion, because I haven't gone in about 4 days, to go to our COVID site and look at all of the information there. It just strikes me that there will be a ton of decisions as to how we provide the information out to people. And I think that you and Mr. Schwartz and Dr. Miller have gotten to meet every day at 8:30 since the dawn of time, or for a long time. And so I just want to kind of flag that a tab to the right vaccine information. We've got a big communications challenge ahead of us in this totally new area. And I know you guys have already thought about it, but I also feel as though just looking at the data we have on cases, there was an evolution in how we provided that data. And I just want to flag, that certainly whatever we can do to help support in the area of communicating out this information, that may be a big part of this next challenge, it seems. Thanks.
Absolutely. Mr. Dorsey, your hand is still up. Did I interrupt you on follow-up questions you had? No. Okay. Mr. Karantonis.
Thank you, Madam Chair. I absolutely agree with Mr. DeFerranti. We also have a population that's undocumented. As you know, there are many other ramifications of holding and managing these data. I have two questions that has to do with any outlook related to logistics here. So eventually we'll have to vaccinate. We have to count that we will have to vaccinate about the entirety of Arlington's population. Where will this happen? These are several thousands of people twice. So in a hopefully relatively short period of time, it will be months. But I guess that our regular hospitals or our regular facilities are, I don't know what kind of facilities would be appropriate for that or what needs to be done. And who would be paying for that? Do I understand correctly that the vaccine will be available for free to the general population?
So yes, the vaccine was paid by the federal government, so no one should be charged for the vaccine anywhere. What providers, so if I were in private practice and had my own, the appropriate ultra cold storage or were part of a system, I can't charge for the vaccine, but I could charge an administration fee for an insured individual, because no one is anticipating that the insurers are going to say no to this. Obviously, it would be, I think, a PR nightmare. That doesn't mean it's not possible, but they have not really felt that that's going to be a barrier in that respect. Same thing would be for the CVSs or Walgreens of the world if, you know, they provide this long term. So the strategy, as we're understanding it and it's evolving, is hopefully we'll have a lot of private providers, including the pharmacy chains, being able to provide for vaccine. That would actually increase the number of options of where people could get to go. Obviously, that's not necessarily what's going to happen in January, but it may be that some of those things can happen by hopefully sometime between April and June. All of this is the devil is in the details and what those groups want to do. What we're planning for in Arlington, just like the other health districts, is being able to provide vaccine through our own auspices and our staff. Obviously, we have to have the same scheduling sort of things as well, because we have to know that we can do it safely and not have people hanging out in less than 6 foot distance and so on, which is why our traditional vaccine clinic models where we would have people queue up would not be what we would do unless we're going to literally have people at 6 foot distances, like circling buildings and so on. So those are the details that we're trying to work through, just like anyone else, to say what's the appointment schedule. We've had some early practice with this, because as you know, we had to do something similar for the childhood vaccinations to get children back into school, had to have the same sort of thing, that we're not going to have people. If you saw our clinics before COVID, we would have, a lot of people packed into those rooms in August, or the waiting rooms in August and September, because everyone was trying to do vaccine catch-up. We can't do that without risking the possibility of germ transmission. So we've had to go to an appointment-based system. And so we would use, at least as one of the sites would be our Sequoia-based clinics. And then we're working to see what would be other locations in the community that we can use as well. But obviously, one of the rate limiting steps there will be making sure that we have the staff as well as the capacity to transport things safely, because we don't want to have the vaccine be ineffective. And so the one advantage of our community is that we're a small community at 26 square miles. Some of you may not know this, but I used to be the health director for the largest health district in Virginia at 2,000 square miles. I will tell you it is much easier, although I know it's hard, but they were able to still get things done with 2,000 square miles. So I believe people will be able to get to, with some inconvenience, if there's another location. But long term, I anticipate, just like what happened with H1N1, we would eventually be providing it only at our Sequoia site, and there would hopefully be other providers in the community as well. But this is that long-term, if all things go well and eventually gets normalized, hopefully those are the things that'll happen. So I think I've speculated way too much, but thank you for that opportunity.
Thank you, Dr. Verghese.
Any other questions? We are to a little after 5 o'clock, and Dr. Verghese has been talking for much of that time, and it's been fine listening to your voice. This has been very helpful. I'm willing to take a little bit more, but I'm worried about wearing you out because you've got an important job you've got to keep doing for a lot longer. So I don't want to wear you out too much. Mr. Dorsey, your hand's still up. Is that because you needed to say anything? If you've got something to add.
Question. Thank you, Madam Chair. Promise this will be my last one.
That's fine. It's okay.
So, Dr. Verghese, I don't know if you've seen, there's been some studies which have at least preliminarily determined that there might be some reduction in the clinical severity of COVID for people who have high levels of the MMR vaccine in their system. And, the working speculation is that's why we see relatively lack of severe cases within children. And the question is not specifically about that study, because if you haven't seen it, I'm sure you don't want to talk about it. But in the interim, while we're waiting for vaccine to be widely available, are you also monitoring what might be other ways in which we can reduce the impact of COVID in our community? So if studies like that pan out and it is determined that high levels of the MMR vaccine actually do ward against severe COVID illness, how would we get all of those messages and information out in light of the Herculean task that you are undertaking with the vaccine distribution?
Okay, so fortunately, I'm not familiar with that specific vaccine question, but I do know that one of the pathways is they are looking across the globe, not necessarily in the U.S., at are there other vaccines that could help with this sort of protection? So having said that, we will still rely on the FDA process. And so we're not going to take a case report or even something published in the New England Journal of Medicine, because that's not public policy. And so when the FDA says these are the vaccines that can be protective, then that is what the Virginia Department of Health, along with all the health departments across the nation, would then be part of that system. But in your example, if it were ever shown and FDA said yes, then obviously we would use the same mechanisms to provide it. The problem becomes, of course, if you, let's say, there are 6 different vaccines of different varieties that can do this, that will be a Herculean task to communicate to the community, as well as when you show up and we have 6 of them, which of those versions are you going to talk about? However, fortunately, I am comfortable saying there's only one maximal type on the horizon, and right now I'm grateful that we have something hopefully coming and that we can work on that and how to communicate messages about that first. So thank you for the question.
Right. And just to be clear, Dr. Verghese, it wasn't to suggest that MMR is a vaccination against COVID, just that high levels of the titer seem to correlate to lower severity of illness. So I'm not adding another thing for you to investigate.
It's okay. Thank you, Mr. Dorsey.
All right. I'm thinking we'll sort of wrap it up. I'm going to give you one question, and I don't want to go too long, but I'm thinking for people watching. So what does this mean for me? So let's say, for example, you're an older person at home, so you're at risk. Let's say you have a private health person who comes into the house to help you out during the week sometimes. And let's say you're wondering, how do I protect myself? Does this person who helps me prioritize for vaccine? How do I know? How do I find out? Where do I go? What do I do? So I don't know that you've got answers to that right now, but I'm thinking people might just try to figure, we've heard all of this priority stuff, but what does that mean for me? Is that a clear question? I don't know.
All right. Well, I will try to answer that, and I did have one more slide about what people can do now.
And briefly is fine, just to touch on it. Yeah.
So on your question, Madam Chair, what I would ask, what are they doing now? Okay.
Yeah.
Because that is the same behavior. It should not matter if they've been vaccinated, because they have to, you and they need to do the same precautions during this time frame. Okay, that is the message that I need to make sure that we all communicate. Vaccine is not a get out of jail free card to do whatever we want to do at this particular moment. It is one of the things, in addition to continued wearing a mask, washing your hands often, staying 6 feet away from people outside of your home bubble, and staying home if you're sick. Because so whatever you're doing now to protect yourself, you need to continue with your home health aid. And I don't know, so I would leave it at that. Obviously doing these things and getting a flu shot. And Kendra, could you put up the last slide, the one that I just sent you? Because I think this goes to the bubble question, and I want to remind people it's a good graphic for people to see.
Oh, yeah.
So stay in your bubble. In the first bubble, doesn't say there's anything. Second bubble, there's a person that has diabetes. The next bubble, no one mentioned. Now you see the one with essential worker. Another one was essential worker, and then a bubble with over 70 years old. So those are separate bubbles. Now imagine those bubbles intersecting. That is what we're talking about, staying in your bubble. And thanks to Colin Ryan Smith, my epidemiologist, for making sure I got this up there. So this is why it matters, because the group with diabetes has adjusted to what it is. We can't tell you what is happening in the other bubbles and vice versa. So my answer to your question in some ways is on this one, Ms. Garvey. Let's stay in our bubbles, even if we're vaccinated. We'll let you know when the epidemiology changes, but this will help us greatly as a community as we learn more about the vaccine, how long the effectiveness is if the FDA approves it. And so let's remember, we still have to hear what happens on the next 2 Thursdays before we can actually say we're moving forward. So.
Thank you. This is a perfect way to end. Really appreciate, because it's sort of, I think the message is kind of like, you keep doing what you're doing now, and we're going to learn more, and people may get some vaccines. I wonder, Mr. Manager, if I just checked out our fact page, we probably need to start a whole new fact page on vaccinations. And maybe at the top, it needs to even start with kind of a message, we have a lot of questions right now. Keep doing what you're doing. Stay in your bubble. Keep others safe. Anyway, I'm not a professional messenger, but I'm just sort of thinking.
What we are going to do is we're going to take this work session, and I know it's gone for a little bit over 2 hours, but I'm always learning, and I think that people should take some time. The information we put out here is the information that right now is the current information. We will be ramping up our communication efforts again and updating our webpage. And I would just encourage people to stay tuned, be patient. And Ruben, you did something very scary at the end where you ran the time lapse on those bubbles getting together. But to make sure people follow the practices of wearing a mask, staying 6 feet apart, washing your hands, and gosh, just hang in there. It's like I've told employees, it's been a marathon. I know we're more than halfway into the marathon. I don't know how far beyond halfway. And as I think somebody said earlier, maybe it was you, that we're sprinting. We've been sprinting all along in this marathon, so we're completely exhausted.
That was Mr. DeFrank. Yeah, we're getting maybe to the heartbreak hill thing in the right, isn't there? And it's really hard, and you got to get through that. You got to save enough to make that last push. So, all right, lots of analogies. I think we've gone on really long. Thank you, Dr. Varghese, Dr. Miller, Mr. Schwartz, and Mr. McIsaac, and all of my colleagues and everybody watching. Just the start of another whole series of issues we've got to deal with. Thank you all very much. Everybody stay well. Keep doing what you're doing. Keep to the bubble. And more later, and we'll take questions, obviously, by email or whatever. And I think with that, we need to give Dr. Varghese a break. But colleagues, we are going into a closed session, so I need, everybody, thank you. This is for everybody. Thank you. I thought we would, I'll do the motion to go into a closed meeting because we need to do that next. We are a little bit late. But then I would propose that we not actually, we'll come together in that closed meeting at about 5:30. So everybody gets just a little break because we have been going on for a while. Does that sound okay to everybody? All right, hold on. I will read the next motion. Thank you so much. Dr. Verghese, stay well.
Thank you.
Yeah. You too, Dr. Miller. All right, thank you. All right, guys, I'll make a motion here. I move that the county board convene a closed meeting as authorized by Virginia Code Section 2.23711A1 for the purpose of discussing a personnel matter involving an appointee of the county board. Do I have a second?
Second.
All in favor, please say aye. Mr. Dorsey?
Aye.
Ms. Crystal?
Aye.
Mr. Carantonis?
Aye.
Mr. DeFranti?
Aye.
Ms. Garvey says aye. All right, colleagues, we are in closed session and we will reconvene right back here. It's probably a separate connection, but we will reconvene at 5:30 and I will see you all in about 15 minutes. Okay? Thank you.
Thank you.